Florio. Welcome to today's DSRIP Project Implementation Plan webinar. This particular webinar covers both the Crisis Stabilization Project 3.a.2 and the Withdrawal Management Ambulatory Detox Project 3.a.4. Today's agenda will provide you with brief updates on governance and project financing, followed by an overview of the current draft of the project implementation plans. The plans have two elements that you see in bullets here. Given that we're covering two projects, simply because they're so interrelated, given that we're covering two projects, I just want to mention we'll go through the requirements in steps. We're not necessarily going to read every item on those slides, but we will have the slides as well as the recording available after the webinar. We won't be doing questions live today. Questions can be sent to the DSRIP mailbox that appears at the end of the webinar, as well as some additional instructions on how to provide feedback. So we'll start with the governance update. You see here the governance milestones that have been set by the Department of Health. These dates are not expected to change. The PPS governance must be finalized by September 30th of this year. Following that date, the PPS will need to establish clinical governance structure, including quality committees, by the end of this calendar year. A few comments on current status. Many of you who've been involved with AHI, PPS since its inception know that governance conversations and development have been going on for quite some time. There was a need to wait to finalize governance until DOH released a document titled Fund Flow and NewCo, meaning new company requirements. That document was released during the last week of June. That document was very important because it explains to us what is and is not allowable in the design of PPS governance. What we now know is that the PPS lead entity, which is AHI, cannot delegate any governing authorities or responsibilities without written approval from DOH. We've known this, but what we needed to know was what will be approved. And what we now know is that all aspects of ownership and control must reside with safety net providers. In addition, an LLC is not an allowable structure. So in order to get a governance model approved, we're still pursuing the development of a shared model. But in order to have that model approved, all aspects of ownership and control must reside with safety net, and we can't do that by forming an LLC. The governing responsibilities and authorities have to be with a not-for-profit, a 501c3. So what are the next steps? How are we going to accomplish this by September 30th? The AHI Members Board, PPS Steering Committee, and Regional Health Innovation Team leaders will be taking part in a series of meetings during July and August to review in much more detail the governing requirements that DOH has put forth and how those requirements affect the options that are in front of us. In addition, we've elicited proposals for some legal consultation, some additional legal consult, and have received responses. We expect to be retaining more legal guidance that is in order to help wrap up this governance formation. We do expect to finalize governance by the September 30th deadline. Failure to do so would impact funding to the PPS. Just a few brief words on project financing, then I will turn it over to Jill Rock. You see the finance milestones in front of you. I know there's been some concerns that contracts are not in place yet. Obviously, governance has to be final before you can contract, but in addition, the financial structure needs to be fully established. And the PPS is required to finalize all aspects of that structure by the end of this calendar year. Here's an illustration of funds distribution. That same document I referred to, the funds flow and NewCo requirements document, has answered most of our questions about allowable funds flow models. one of the requirements is that 95% of the funding flow to or through safety net providers. One of our questions that we had posed to DOH was, if there's an initial distribution to a safety net, can that safety net provider in turn contract with a non-safety net provider for aspects of their project implementation or for other contracted services they might need on that implementation? And now we know the answer to that question is yes. So there's basically at that first level from the PPS to a safety net provider, that first wave of distribution is where that 95% rule applies. Then there can be a subsequent wave, and they can go out to non-safety net partners after that. So just a few final comments on funds flow and project financing. We do expect that the PPS will be entering into performance-based agreements with performance partners. A performance partner is a safety net organization that is willing to share risk with the lead. Those performance partners must be safety net. They're sharing risk. I'd expect they'd be part of governance. And again, they can in turn enter into non-performance-based contracts with other organizations. So we do expect that when it comes to contracts for services, that the PPS lead will need to contract for some services. Performance partners will also need to contract for services. And the nature of those agreements would be determined by that contracting entity, either AHI or the performance partner. So for either phase of this, it's likely to be a requirement that the organization providing the service submits detailed work plans and or budgets. But at this point in time, those are not being required here at AHI or by the Department of Health. So clearly you would need to be establishing a detailed work plan, in part to be sure that you've fully laid out the scope of work, know all the costs that will be associated with that, and that you have a tool to manage internally the progress on that project. So with that, I am going to turn it over to Jill Rock. Jill's our project manager that is going to cover the implementation plan overview and then the requirements and risks and mitigation for 2 projects. So I'll turn it over to you, Jill.
Thanks, Colleen. So first is we'll start with a project implementation plan for the 3.a.2. And just a couple things to remember is that the requirements that I'm going to go over they are set by DOH and some of the target dates as well. And the implementation plan is due July 31st, and it will drive all reporting. It will drive all the reporting. So we just want you to, there's a couple questions when I'm going over the plan is, in the steps, is that we really need your feedback. So some of the things to remember are these steps comprehensive enough? Are they unnecessary? Which ones are unnecessary? Are they clearly stated? Do they flow? We really need your feedback on a lot of these requirements and the steps. And we will go over that at the end and how you can reach us. So for project 3.a.2, all of the participating sites must meet the project requirements by March 31st, 2017, which is known as DSRIP Year 2, Quarter 4. So the first Department of Health requirement is to implement a crisis intervention program that at minimum includes outreach, mobile crisis, and intensive crisis services. And the steps that we have identified right now is just basically identify and list the organizations that will perform crisis outreach, mobile crisis services, and intensive crisis services. And I should mention to look at the target dates as we go through these. So for requirement 2 is to establish clear linkages with health homes, ER, and hospital services to develop and implement protocols for diversion of patients from emergency room and inpatient services. And some of our steps are identify the health homes, ERs, and hospitals in the PPS, develop diversion management protocols, and implement the protocols, specifically with the emergency room department. Our number 3 requirement from the state is to establish agreements with the Medicaid Managed Care organizations. and we need to identify these NCOs in the PPS. We need to start scheduling meetings and engage in payment negotiation with the NCOs to get community crisis stabilization services covered. Requirement 4, develop written treatment protocols with consensus from participating providers and facilities. And you'll see the end of DSRIP year 2 is set by COH, and that target date is March 31st, 2017. So this requirement can be no later than that. And for the steps, we have hold regularly scheduled meetings, develop the treatment protocols, and then train the staff on the treatment protocols. So as you see, some of these we really need to list out more steps and become, and they need to be more comprehensive. So again, we really need your feedback. Requirement 5 is include at least one hospital with specific specialty psychiatric services and crisis-oriented psychiatric services. And this, again, is set by DOH, and that is the end of DSRIP year 2. And some of our steps are identify the hospitals, evaluate access to the psychiatric services, identify and list areas that need improvement, and implement improvement steps. Our requirement 6 for this project is expand access to observation unit within a hospital, outpatient, or at an off-campus crisis residence for stabilization monitoring services. So some of these steps that we've identified is, again, identifying the hospitals and the PPS that have the observation units, evaluate the access to the observation sites, identify improvement steps and steps needed to improve, and implement those steps. Requirement 7 is to deploy mobile crisis team to provide crisis stabilization services using evidence-based protocols developed by medical staff. And some of these steps, you'll see they're kind of repetitive. We need to identify the organization, develop evidence-based protocols. We need to develop the implementation plan. And then we need to also train our mobile crisis teams on the protocols. Our number 8 requirement is ensure that all PPS safety net providers are actively connected EHR systems with local health information exchange. So these steps are to coordinate with the HIT work group projects 2A2 and projects 3A1. So those are most of our steps, are to coordinate with those projects and then to train the staff on the EHRs. Requirement 9 is to establish central triage service with agreements among participating psychiatrists, mental health, behavioral health, and substance abuse providers. And some of the steps that we've listed out here are to list the participating providers that will be part of the central triage service, identify organizations that will house it, develop policies and procedures, train your staff, and then implementation. Requirement 10 is to ensure quality committee is established for oversight and surveillance of compliance with protocols and quality of care. And this is, again, the end of DSRIP year 2. So you can see all the steps here is to establish subcommittees. You'll see on step 5, there's the attachment down there that you can look at. That is the attachment J, domain 3. There's the link down there that you can look at. So that is requirement 10. Again, those are set by the state, the dates. And our requirement 11 is to use EHRs or other technical platforms to track all patients engaged in this project. And that is the end of DSRIP year 2 again, and it's to identify targeted patient population and to track actively engaged patients. So now we'll go over a couple of the risks and mitigation for this project. So one of the first risks is awareness and getting clients to utilize this new service. And the potential impact to the timeline is if patients are unaware of this new service or how to access other current services outside of an emergency room visit, the number of engaged patients could be delayed. And our mitigation strategy is this can be addressed through education, training, and community information sharing. Another risk is having a financially viable crisis service, and the impact to the timeline is that it has less impact to the initial timeline, but possibly more impact as the DSRIP year progresses. And this can be addressed initially through DSRIP funding with push to get Medicaid Managed Care to provide reimbursement for services. Another risk is transportation. And if patients are not able to get to their services, then the number of patients would be lowered, that were engaged would be lowered. So utilizing DSRIP funds to purchase vehicles is one of our mitigation strategies, as well as telemedicine and utilizing the mobile teams to go where the clients are. Staffing shortages is another risk. If there is difficulty recruiting qualified staff to work on crisis projects, this could delay implementation services. In regions where ambulatory detox will be co-located, the idea of shared staff members that are cross-trained will help meet this need. That is one of our mitigation strategies for that. Another risk is training needs, and the potential impact to the timeline is depending on the number of staff to be trained or retrained, this could slow down implementation. Our mitigation strategy is adequate trainings to ensure ability to manage a variety of crises, as well as training on safety. And our last risk that we have identified in this project is access to EHRs. And depending on how long the technology solution takes to implement this could delay meeting certain deliverables for this project. And we have contracted with KPMG to assist our HIT work group in looking at this technology solutions. So that's one of our mitigation strategies for that. So now I will go over the implementation plan for 3A4, withdrawal management and ambulatory detoxification. So for this project, all participating sites will meet all project requirements September 30th, 2019, DSRIP year 4, quarter 2, 18, my fault. September 30th, 2018. And that's DSRIP year 4, quarter 2. So our first, some of these requirements are very similar, so I'll go over the ones that were not included in the last project. So number 1 is develop community-based addiction treatment programs that include outpatient SUD sites with integrated PCP teams. So some of our steps, and again, to reiterate what I said before, we're looking for more feedback from you. So some of the steps that we have come up with is develop community-based addiction treatment, establish integrated primary care providers, and also the stabilization services, including social services. Requirement 2 for this project is establish referral relationships between community treatment programs and inpatient detoxification services with development of referral protocols. So some of the steps are identify substance use disorder treatment programs, identify detox programs. We need to establish SUD provider group. We need to develop evidence-based protocols, referral procedures, and then we need to implement the referral procedures between the community treatment programs and the detox services. Requirement 3 is include a project medical director board certified in addiction medicine with training and privileges with familiarity with withdrawal management agents. So the steps that we came up with this is create a job description. We're going to post the job opening, recruit for a medical director, hold interviews, offer position to qualified applicant and execute signed contract of employment. And that is a target date of March 31st, 2017, which the state has come up with for us. Requirement 4, identify and link to providers approved for outpatient medication management of opioid addiction who agree to provide continued maintenance therapy and collaborate with the treatment program and care manager. Some of the steps are develop and maintain a complete list of these providers, including community-based and inpatient. Identify which providers are willing to work collaboratively with the care managers in written agreements. Requirement 5 is develop community-based withdrawal management protocols based upon evidence-based best practice and staff training. So we're going to develop these evidence-based protocols. We're going to develop an implementation plan. We're going to establish policies and procedures, and then we will train staff on the detox care protocols. Requirement 6 for this project is develop care management services within SUD treatment program. Some of the steps: identify care management services, develop evidence-based care protocols, develop an implementation plan, and train staff on care management services, which must provide written training materials. And you'll see requirement 7 is the same as one of the requirements in the previous project, so I don't need to go over that. It's the Form A agreements with the MCOs, as well as requirement 8 with the use of the EHRs. So those are the requirements for that project. I will now go over some risks and mitigation. So one of the risks of this project is in Plattsburgh finding a board-certified addiction medicine doctor, and staffing is also significant for this project. So the potential impact to the timeline is, and until a doctor is on board, the implementation in Plattsburgh may not be able to begin. And a mitigation strategy is a waiver request will be sent to OASIS with the ambulatory detox application. Another risk is in Saranac Lake. Challenges will include the development of and training certification for the peer support program. What else? And then also trying to find a psychiatric nurse practitioner. If patients do not have access to the right level of service, you risk having too many patients pushed into the wrong level of care. And one of our mitigation strategies is working closely with Plattsburgh region, as well as bringing in experts to develop protocols, and staff training will help spread the burden across the region and increase positive outcomes. Another risk, again, in this project is transportation. And if patients cannot get to a service, fewer patients will be served. Mitigation strategy, ensuring staff have knowledge of resources to assist clients with obtaining transportation. Another risk is incorporating care management services. The potential impact to the timeline is if patients do not have access to care coordination and resources to meet basic needs, they may end up relapsing and then would need to re-engage in detox services. Mitigation strategy is working with our health home programs to ensure enough care coordinators are available to meet the client-based demand. Another risk, integration of PCP teams into outpatient SUD sites. If a patient is not medical stable or has an underlying medical condition that isn't being addressed, this could cause delay in successful treatment. And the mitigation strategy is ensuring staff have the knowledge of resources to assist those clients. Another risk is having enough prescribers for withdrawal management medication. Potential impact to the timeline is lack of prescribers would mean fewer patients could access services. And our strategy is the PPS organization will engage in active recruitment for prescribers to ensure that there are enough. And our last risk for this project is ensuring you have patients who will be successful in an ambulatory detox program. Lack of successful patients will reduce the amount of clients going through the program. And our mitigation strategy is ensuring staff are trained to assess the needed level of detox care along with working collaboratively with other detox programs. So that is it for the 2 projects for the implementation plan and the risks and mitigations. And as Colleen said before, we will not be taking live questions today, but you'll be able to provide feedback to us by, if you have feedback, and again, we really welcome it, if you could give it to us by July 21st, and in the subject line, IP feedback, and our email address is DSRIPAHI@adkhi.org. That is all we have for you today, so thank you again for listening.
In closing, just as a reminder, a copy of today's webinar as well as a copy of the implementation plan drafts will be posted to AHI's website, and a notification will go out to you once that posting has occurred. All feedback is welcomed and appreciated. However, we want to remind you that we know it's a short turnaround and it is optional. Thank you so much for taking part of today's webinar. Have a great afternoon.